Hello, everyone, and good morning, and welcome to today's question and answer session. I'm going to fix my camera here a little bit. It's a little bit of a new setup for me, so hang in there. Welcome. Hope everybody's having a good day so far. So I just had a few questions that were sent to me that I wanted to make sure I got answered today. And then if anybody else has anything, please let me know. I'd be more than happy to answer anything you've got for me. So the very first question I got emailed was, what if these approaches or my concentration and memory problems are due to other causes other than like a dementia or a cognitive decline in the traditional sense? Will these methods work? And really the answer is yes, that this approach of a lifestyle change will protect our overall aging process the best as it can. It's going to help us age in a healthy way and help us have the best longevity that we can. Most of these approaches will do things like reduce type 2 diabetes, reduce cardiovascular disease, and all of these things. So these approaches will help support our body in its ability to kind of just clean itself up and stay as healthy as possible as long as possible. So like, for example, some of the other causes of cognitive decline can be chronic traumatic encephalopathy, which is, excessive head injuries and that kind of stuff. But that also causes metabolic changes in the brain. So when we're struggling with metabolic changes in the brain, then we can support the brain's ability to heal with these same techniques. And diet is always going to be the primary for any of these things. We have to clean up our diet in order to make sure that we can heal appropriately and be as healthy as possible. Okay, so that's question number one. All right. The next one I was sent was, if I'm forgetting things, should I ask my PCP for a referral to a specialist? This is an interesting question because the question can be, what kind of specialist? Do I need to go to a psychologist first? Do I need to go to a neurologist? What can be handled? And a lot of times that's going to depend on your PCP and what they feel comfortable handling. So your primary care a lot of the times can do a lot of the initial testing and try to figure out, okay, what is really going on before they say, okay, it's time to go to a neurologist. If you live in a community like I do where there's very few neurologists available, a lot of times the PCPs will be handling these things as much as they possibly can up front before they send them to a neurologist, because the wait time is so long and we want to treat as many treatable causes as they possibly can before they send them to a specialist. And you might not find a specialist that does cognitive decline or dementia, even though all neurologists are trained in that. That may not be their specialty. They may like neuropathy, or they may be more into other nerve things, or they may be more into strokes, or a lot of times we have epilepsy specialists and those things as well. So you want to be a little bit careful about which one you can go to. A general neurologist is going to be just fine, but you will get the best possible care if you go with a specialist that really, really enjoys and is focused on this type of work, because they're going to be up on the latest stuff. Because the body is so complex, people don't always, have the time to go through everything under the sun in order to fix and learn all the things that they need to do in order to help people get better. I mean, it is just, there's so much to the brain that they are always going to have probably a subspecialty underneath their overall arching specialty of neurology. So get to know your specialists, and if you're selecting a neurologist, and ask them kind of what their interest is in this area, if that's really something you're concerned about. Same goes true if you choose to go to a psychologist to do more of the functional testing first. If you have one that is a neuropsychologist, and what their specialty is and what they're really interested in is going to be important. Because if you find one like me who's really interested in cognitive decline and how the brain ages, then you're going to get someone that maybe stays up on that stuff a little bit more. A psychologist that is a little bit more of a generalist and doesn't have training in neuropsychology testing testing is probably not going to understand to the depth of this level what cognitive decline looks like and that kind of thing. So ask questions. Don't be afraid to figure out what the specialist does, what they're kind of interested in. And the same goes true for your primary care. The more knowledgeable you are, the better you can advocate for yourself, and you can get the primary care to do the things that you need them to do. Depending on how much they do an elderly population may depend on how much they deal with stuff like this as well. Family medicine may do a lot more children and younger generation. More the ones that do a lot more Medicare may be much more inclined to do this kind of work because they face an older population in general, and they're going to kind of help that kind of population in the Medicare screenings and figure out what they need to do as far as they age, because they have a lot more regulations and rules for Medicare and people as they heal and that kind of thing. So those are some of the things to ask your primary care. Do they feel like they can handle something like this in the early stages? And most of them can just fine, especially if they're really interested in reading the reports that come from a psychologist or somebody like that may kind of tell them what the functional brain is doing. And sometimes the primary care is going to say, go to a psychologist or someone that can test the functionality of the brain before they send them to get an MRI, because some of the insurances are starting to have some more rules on how they justify imaging, because imaging can be expensive. And there's a bunch of different kinds of imaging that can be done when you're looking at cognitive decline. And the gold standard is one that, especially if you're looking for Alzheimer's, is an MRI with hippocampal volumetrics, but not everyone can do that. In my community, there's only one place that has I think it's a 4 Tesla magnet or something like that. It's the very high level magnet that can get the level of detail they're looking at, where they can do the volumetrics, which just means they take a picture of the hippocampus and measures it against a statistical model to figure out, is this within the normal ranges for shrinkage for that age, or is it outside the age range? Now, hippocampal volumetrics, if you ask for something like that, it may or may not be extremely accurate, because it doesn't account for if you've had previous hippocampal problems, because sometimes early childhood stress and chronic trauma will cause shrinkage in the hippocampus in general. So we just kind of want to be aware of that and not discount some of these things as good information when we're trying to figure out what the cause of the cognitive decline is. Another thing that can be helpful is, nobody I talk to ever wants to do this, is to go to someone that can do a spinal tap and actually look at cerebral spinal fluid and whether or not there's beta amyloid or tau within that cerebral spinal fluid. Because the more that information can tell us kind of where you're at in the decline process, because beta amyloid will go up in the beginning, and then when it starts developing tau, the beta amyloid actually will go down, and then tau will go up. But that typically only is going to apply when somebody is kind of progressing through the Alzheimer's process. It won't necessarily show up in other types of cognitive decline, like the vascular dementia or even frontotemporal dementia, which we don't see as much, but is definitely possible. So those are just some things to talk about with your primary care, especially if you have a family history of those kinds of things. The other thing to kind of consider is talk about other things that could cause cognitive decline, because they may not always know to ask, or it may not occur to them. Especially one of the things that's starting to come up and be more prevalent, and which will continue to come up in the future, is latent infections. So originally we have found that infections that never truly go away, or that can go back up, like it's the herpes virus, the HIV, those kinds of things, those will kind of come back up. And if the viral load increases again in the body, hepatitis is another one. If those go back and increase in the body, it can cause inflammation in the brain and create a very similar thing to what's going on with Alzheimer's, and then the body is kind of trying to deal with that kind of infection and that inflammation. I suspect we will start to see a lot more of that now that we are following coronavirus, and as that kind of, and the SARS-CoV-2, as that kind of goes away, we don't know how latent that is going to be in the body yet, because it's only been, a little bit over a year that this has been out, and we just don't know what it's going to look like long term. So we're going to have to start kind of being aware of some of those things as they come out, and the research starts to develop on that, and to kind of see what's going on. Years and years and years ago, they used to see a high level of dementia in conjunction with syphilis, but now that we can treat syphilis, and we treat that early on with penicillin, they see much less of those correlations. But that's just an example of how ongoing infections will continue to cause difficulty in the brain, and continue to contribute to decline, in some form or another. Another person writes something very similar, that when they're asking for a specialist, or what tests they should ask of their primary care. If they're going in, they're worried about memory loss. Okay, so that's another great question, because most of the primary cares are going to know what they need to order, but they might not necessarily know unless it's requested by a specialist, either a neurologist or a neuropsychologist. And that, of course, depends upon the training of the primary care, and how, like I said earlier, how interested are they in cognitive decline and dementias and that kind of population as they typically see. So some of the things to think about, but they may or may not be covered by insurance, and that therein lies the challenge. Do you want to pay for some of these because you really care about your health? Or do you want to run the risk and just supplement? That's always an option. Or just, see if your insurance will cover it, because sometimes we can work a little bit harder to kind of justify those things if we do the testing first. Okay. So, to just undo the rule out. Sometimes they don't want to do any of the testing, which is, I don't understand why insurance is like this, but they'll pay for the neuropsychological testing, which is probably almost as expensive as the lab testing, just to see if we better roll this stuff out. It's a little bit odd, but it's the way it works. So one of the things to think about, of course, is some of the real basic biological support that we can give the body. So the vitamin D is a big one. We see tons of people with low vitamin D, especially in the winter, but it's also just due to we're wearing a lot of sunscreen. We're not outside as much, especially during this pandemic. That's kind of contributed to some loss of that kind of nutrients in the body. Some of us have genetics, like myself, that don't convert vitamin D very well, so we have to supplement much, much more. So that's a good test to have just in general, to know what your health is. And it also declines as we age in general. I heard through the grapevine that some insurances aren't covering this anymore because people were requesting it so much. I find that outrageous myself. And if I were you and you were worried about that kind of thing, I actually would, in my insurance, didn't want to pay for it. And I either had a diagnosis of depression or cognitive decline or memory loss or an infectious process, and they didn't want to cover it, I'd make a complaint with the insurance commissioner, because I think it's really, really important that these insurance companies be held accountable for what we're paying them for, and to deny some of these real basic things, which we then could buy our own supplements, because of course they're not going to cover that, but to get a basic test to find out, where you're at, and to see if our supplementation is working. And so vitamin D is a real basic one, because it's part of our immune system. It's part of depression. I'm always amazed at how many people we just put on antidepressants without checking some of this first. And that doesn't mean you don't need an antidepressant or any other kind of medication, but you might need less of it if we can treat it biologically first and just support the body the best we can. So those are some of the initial things to start. Another one we're seeing a lot of is just general B12 and folate. And we've talked a lot about the food industry over this course, and because if we're not eating a lot of leafy greens, which most of us aren't in the American diet, we're actually finding a lot of low B12. And I am surprised consistently when I get referrals where they've not checked the B12. I actually just got one the other day. Somebody that had complained of cognitive decline and some memory issues, and they wanted to get him tested. And I looked back in his history, and he had a different issue, and I don't remember what it was, but they had tested him, I don't know, 2 or 3 years ago for B12, and for some reason, and it wasn't memory loss at that point, but something else, but neuropathy, I think it was, because that's common in neuropathy. And he had a low B12 there, and so it doesn't look like before they sent me the referral, that they repeated the test to figure out where it was, because this is probably a dietary issue that he could treat really easily with supplementation. Because if he was having neuropathy issues, a lot of times the B12 is not even in what they call the low range. A lot of times it's just below 400. And you can start seeing neuropathy and nerve issues when it starts to drop down that low, where it's like kind of what we call subclinical, and not quite as damaged yet as we would expect to see true, when it starts being considered a deficiency. That is one of those things that could be easily supplemented with the B12 and the folate, but a lot of the times we don't necessarily know what the level is. And then, do you want to just waste a bunch of money on supplements? Not necessarily. So we kind of want to know where we're at. At least I like that measurement to kind of pay attention to see what's going on with our bodies before we just kind of throw good after bad and that kind of thing. So kind of keep that in mind. And folate goes along with that as well. The less we're eating of supplemented foods and we're kind of eating natural foods, we're looking for natural folates. And we might not have the best diets still, even after we're making these changes. So then we kind of need to pay attention to that and just kind of see where we're at. And there's a couple other B vitamins they could do as well, but those are actually the most common. The next one that I would ask for, which may or may not be done with a metabolic panel, is your A1C. They might do your fasting glucose, in general to kind of see where you're at. But unless you're checking that every day, you might not necessarily have a consistently high fasting blood glucose. We kind of need to figure that out, because you could be pre-diabetic or on that borderline, like we've talked about with this insulin resistance for many, 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 many years before getting diabetes. You can actually also reverse diabetes. And, if diabetes is really defined as an A1C of over, I think the level is now 5.7 or something like that, or 5.6. If you can drop your A1C through dietary changes below that, then technically you don't have diabetes anymore, because that diabetes type 2, that is, because that insulin resistance has been changed to reverse, so that you're not insulin resistant anymore, and you're kind of more balanced out. I actually had a patient do that more in relation to his anxiety than cognitive decline, even though he did complain of that somewhat as well, but he had mostly stomach issues and cognition or anxiety issues. And when he cut a lot of the sugar, he started feeling a lot better, and his A1C dropped to 5.4, and he was well on his way to being taken off his metformin and stuff like that as well. So that's a good one to consider. A less common one is homocysteine, which is a marker of inflammation in the brain, and can be some indication of difficulties with those B vitamins and those complex B vitamins. A lot of times I find people, we want it to be like below 7. And I find people really consistently in like over 15, and sometimes in their 20s. And that's really, really a marker of inflammation throughout the brain. And those are typically your patients that don't eat very well, drink excessively, and a lot of times smoke as well. And if there's an MRI that accompanies that, we often see that kind of cortical atrophy, the shrinkage throughout the brain, because the blood vessels just don't have the flexibility that they were looking for, that they had before. So it's kind of, important to kind of monitor that a little bit. And then the really only way to treat that, there are no medications that treat it. You can't use an anti-inflammatory. You really have to support the body with the appropriate foods and vitamins that you need to kind of reduce that. And there's some pretty significant research out there that supports that. So that's in a nutshell of what you should look for. There's a few other tests that sometimes can help, but they don't always ask for them unless there's some really specific reason to do it, such as like, latent infections and those kinds of things. So those are the primary ones. And those are the ones if I had to narrow it down, those would be my top ones, my top 5 that I would do if it were me. There's a few others that I always get my doctor to do if I can get him to do them, just because I like to monitor that kind of stuff. But those are the top ones. All right, one more question that I've got, unless anybody else come up with something else they're thinking about. This looks like Michelle writes to me, my doctor wants me to take aerocept, aka donepezil, or Namenda. Should I take it? Good question. Now, I'm not a medical doctor, so I can't answer that directly, but I can help you think about this in a critical way for you, okay? Because there's a risk-benefit towards every type of medication. Some people do really well on these medications, and some people don't. It just kind of depends. So let me talk for a brief minute about what those are. So aerocept or donepezil is a medication designed to prevent the breakdown of acetylcholine in the brain. So it inhibits the enzyme that breaks that down. So in a nutshell, our neurotransmitters are built up, they're used, and then the body develops an enzyme that breaks them down. And then they break down into their pieces, and then they're built again, and then they're used, and then they break down. So they are in this cycle. And it's basically, you could think of them kind of like Legos. They are built up into their item, whatever it is, a spaceship or whatever you're building, played with, broken down, and built up into typically the same thing, though, not something else. So when we think about that, and then let's talk about acetylcholine for a minute. Acetylcholine is concentrated most in the hippocampus, which is where we remember things, okay, and where we store our memories. So if we are having problems in the hippocampus, that, or because of Alzheimer's or something like that, some increase in acetylcholine may help remember things a little bit better and store information a little bit better. So it kind of helps the functionality, but does nothing, absolutely nothing, to prevent the decline of and the increase in the beta amyloid and the tau. It doesn't do any of that. It just helps the functionality in the moment. So, and it's mostly for people that are in moderate Alzheimer's. That's what it's approved for. Sometimes we'll see it used in mild cognitive impairment. But it's kind of a mixed bag. I always ask people, do you think it helps? Does it not help? And it's kind of seems like 50-50. Sometimes it helps, sometimes it doesn't. And so sometimes I think that's because people are started on that before we know what their true diagnosis is. And then once we get all this other stuff run and all the tests, and then we figure out, I don't know that this is true Alzheimer's, that this is a lot of beta amyloid, this may be more vascular in nature or more metabolic in nature. So sometimes after a little while, those things come out, and that may be why the medicine doesn't work. Now, sometimes medicines are used for diagnostic purposes. You give them to somebody so you can see if they work, so that you can help with the diagnosis. That happens quite often, but that one's probably not really that accurate regarding that. There's some other things that sometimes they don't always look at when you're giving some of these medications. I've actually found people that were given this medication, even though they were on other medications that actually decrease their acetylcholine. There's some medications that are anticholinergic and that are quite commonly given. And so sometimes then to me, okay, are you just giving the donepezil to balance out these other medications that are kind of reducing your acetylcholine. And some of the ones that are most common are the benzodiazepines, like your Xanax, Klonopins, things like that. The other most common one is antidizziness medications like meclizine that can continue to cause that kind of decline in the acetylcholine in the brain. So that's one of those things that you kind of have to look at the overall picture before you decide, maybe I should reduce some of this and do something different in this area before adding this medication. And then it becomes a personal preference. Do you want a more medication approach, or do you want a more natural approach? And sometimes that's really up to you, and figuring out what the risks versus the benefits are. Namenda is, and then sometimes they'll say Namzaric. Namzaric is one that actually combines basically Namenda and donepezil. So Namenda is one that is designed to increase the BDNF, brain-derived neurotropic factor, which is kind of the growth factor for the brain, and helps kind of maintain that, all the neurons and their connections and stuff throughout the brain. Now, that decreases as we age naturally. So there's a couple different ways we can increase that. And we haven't even gotten into this one a lot yet in this series, but exercise is actually one of the best ways to increase BDNF. And so, the research is still kind of, up in the air. They of course can raise the levels of BDNF through this medication, but we're not really sure about how effective it is at preventing decline or helping the overall functionality. Again, it depends upon what's really truly going on in the brain. And a lot of these things are very hard to figure out because the brain is so complex. So we, again, encourage people to look at the pros and cons of all of it before you make a decision, because I can't tell anyone in a generality that they should or shouldn't take this medication. It just kind of depends on their situation. And some people have side effects and some people don't. So you got to have to consider that as well. So I tell people, have a good, honest conversation with your provider, and a good provider will listen to your concerns and help you understand them. I personally am not a blind follower of anybody medically, and I encourage many people to not be a blind follower and to advocate for yourself. And if you have a provider that doesn't want to answer your questions or doesn't want to listen to your concerns, I would find another provider, because you want to feel comfortable and have less anxiety with your treatment and with your approaches, so that you can make sure you're getting the best care possible. So don't be afraid to advocate for yourself. So I'll have a few more minutes for any more questions should they pop up. Hopefully that kind of helps with some things about cognitive decline and making choices for your healthcare. Again, if you like what you hear in this series, please share these videos with other people. Don't forget to subscribe and hit the thumbs up button so we can get more people involved in the community. And don't forget to download my 5 free videos on your tips to your best emotional and physical health, because after we finish some of this cognitive decline series regarding the eating and we start getting more into sleep, we're going to start getting more into stress management, which will kind of lead us a little back into developmental trauma and that kind of stuff as well. That's kind of what we're looking at in the future. Is we use this term stress management in general, and that's just such a broad term. What does that mean? Oh, does it mean you're going to meditate a little bit? Does it mean you're going to do this? I want to provide you a little bit of education on why managing stress is so important and how to deal with today's stressful world in order to protect our longevity, not only for our body, but for our brains as well. So if I don't have any further questions, I want to wish you guys a happy Saturday and enjoy your time. Hopefully the weather is nice as it is where you are, as it is where I am. So with that, have a great day, and I will talk with you all later.